Hey everybody, we're going to be speaking about proving and disproving the hypotheses generated during differential diagnosis or during diagnosis, and how differential diagnosis plays a role in this. So onwards. Okay, what about differential diagnosis? We've talked about this a little bit previously. Let's delve a little bit more into it, because it is really the differential diagnosis that proves or disproves your hypothesis when you get right down to it. So differential diagnosis of the process is usually a matter of listing the conditions that may give you pain in the patient's area, and then basically checking each one out by proving it. So you'd actually do a full exam on each one of these things and say, yeah, this is it. Finally, out of all these, in this case, 8 things, this particular thing is what we see as a cause. So the example I'm giving here is lateral elbow pain. So if you look at the differential diagnosis, we've got tennis elbow, common extensive tendinosis, brachioradialis degenerate tear, lateral collateral ligament degenerate tear, assuming these are all non-traumatic, ulnar-humeral joint biomechanical dysfunction, radio-humeral joint and superior radio-ulnar joint biomechanical dysfunctions, elbow arthritis, and it could be referred from the C-spine or shoulder. Not all of these are equally probable or probable at all. I don't think I've ever seen a brachioradialis tear, either a degenerate one or a traumatic one, but they're on there for the sake of argument. So basically your proving test will be the things that you would expect to see positive if those conditions are present. Essentially, if you're doing script focused hypothetical inference, that would be the essential illness script for that condition. There's another way of doing it though that actually makes more sense. We've got the same 8 conditions listed, but now instead of trying to prove it with the EIS, we disprove it. For example, we know that if you've got a tendinosis, the tendon has to be tender. So this is got to be as close to 100% sensitivity as you can get. So if that is negative, then you don't have a common extensive tendinosis. Similarly, the same thing with the brachioradialis tear and the lateral ligament. They're all vulnerable to palpation. If they're in trouble, they will give you tenderness. If not, you won't get the tenderness. So a simple test will eliminate all those 3 things at once. For the joint problems, essentially the quadrant tests will do this. If the quadrant tests are negative, if all of them are negative, then you know you don't have a joint problem. If, for example, though it's an arthritis, then you would expect basically the quadrant tests that move it towards the ends of range in close pack position more than anything else to be positive. And if it's a significant arthritis, that is, there's enough there to really give you some problems, then you would expect all 4 quadrants to be painful. Whereas with, say, an abducted ulnar, you may only expect one of the flexion quadrants to be positive or whatever you have. But the quadrant tests all being negative would eliminate the joints as one of the areas. Now, essentially, if you've done all of that, you're left with something that isn't the joint. The only thing that can be is referred. Now, if you want to eliminate referred pain here, then your positive tests around the area, which you've already done, will be positive. So you leave looking for referred pain until last, basically. Get everything else out of the way. And then test it by doing quadrant tests and so on. But it's difficult to actually reproduce referred pain by messing with the spine. So it's a matter of negative findings in the local area and negative findings on function. So this won't be elbow or hand function that gives you trouble. It'll be positions of the neck, moving the neck and so on. So differential diagnosis as a process to make a diagnosis isn't too terrible. The only thing that is difficult though is disproving the absence of a condition. And some of these tests, for example, the quadrant test, if they're positive, you can't say there is not a tendinosis there, because there may be a joint problem and a tendinosis. So proving the absence of something is, as always, very difficult. But as a quick screen, a quick way of getting rid of things, these screening tests are good, providing they're highly sensitive in the process of eliminating conditions. So as a quick review, using script focused hypothetical inference, we use proving tests, obviously. I say obviously, I'm going to show you an alternate method of doing this, but this is the one we've been using. So we generate a hypothesis immediately based usually on where the pain is. And if you like, this is a differential diagnosis, although we're not considered as a diagnosis. But it's certainly differential hypothesizing. So we have the hypothesis, we attack it with the essential illness script. So we apply the essential illness script to the hypothesis and see if it works. Now, if the EIS is good, we can then do disproving tests. So quadrants, although this won't necessarily disprove tennis elbow, it will implicate the elbow, for example. Now, we should have already done palpation when we were doing a proving test, but if the palpation turns out to be negative, we've disproved it. Anyway, if our disproving tests are negative, we have our diagnosis. If our disproving tests are positive, that is, it refutes the hypothesis, then we have to generate H2. So the disproving tests are a check on the EIS being good. It's also a way of decreasing bias, because you're basically checking yourself against a hypothesis. If the EIS fails, we go to H2 and then repeat the whole process again and again until we get our answer. So in most cases, this is fairly straightforward. It's simple enough. It's when things don't go terribly well and H1 fails, H2 fails, H3 fails, and we start getting deeper into this. But this is the way that we've been doing it, and it's a fairly standard way of doing an examination. But let's look at a different way of doing it. So we have our H1, but instead of applying the EIS to it, we apply a disproving test to it. And that, as I say, could be palpation of the tendon to see if it's tender. As your first test, before you take a history or anything else, go in there, palpate the tendon, and if that's not tendon, move on. Now, this is what most experienced therapists do. This is part of pattern recognition. It's your check on pattern recognition. So it's what most experienced therapists do. They don't ask a lot of questions about it until they know what questions to ask. They'll go in there and basically do a quick test to make sure they're on the right track. So if the test disproves it, we can move on to another hypothesis. So now, if the disproving test is positive, we have to move to H2. This is assuming that disproving test is both very, very sensitive and you're doing it correctly. So if we come up with a second hypothesis, we do exactly the same again, a disproving test. Now, if the disproving test fails, then we have our new hypothesis is stronger. We can apply the EIS to it. If that works out to be good, then we have our second hypothesis now as a diagnosis. If the disproving test is good, that is, it disproves the hypothesis, then we have to generate a new hypothesis, which is H3, and then we go through the whole same process all over again. If the original disproving test is negative, then basically it fails to disprove the hypothesis. We go to H1 is stronger again, and now we do our proving test. If these are good, then you can move on to H1 being the diagnosis. So instead of going through the whole EIS until you know that that condition is possible, even if the disproving test said it's impossible, there's no point in doing the EIS. So the disproving test is one test generally, or one question, whereas the EIS is 4 or 5 tests and questions. So it makes sense to do the disproving test first. And as I say, it's what most experienced therapists do. They'll simply go in there, if some ligament problem, they'll just go and palpate it and say, yeah, that's not it. What else could it be? Or, yeah, there we go, it's tender, now let's investigate it. Let's have a look at a concrete example. We're going to take the hypothesis and do the routine, regular way of testing the hypothesis by trying to prove it rather than disprove it. So we've got our diagnosis, our hypothesis rather, of degenerate labral tear. We attack it with the illness script. These are proving tests. They're good. We have our hypothesis turned into a diagnosis. If, on the other hand, the EIS fails, we have to move on to a second hypothesis, which we'll say is a biceps tendinopathy. Could be anything, but we're going to say a biceps tendinopathy. If that fails, we're going to move upwards, and we have to come to H3. any other tendinopathy. You can name it. Supraspinatus, infraspinatus, don't really care. You're going to have to do the same for each one, but another tendinopathy. And then we'll attack it with the EIS as a proving test. If that's good, our hypothesis now is a diagnosis. Once we've got that diagnosis in, we have to review the diagnosis by trying to disprove it. This is bias correction. We attack it with disproving tests, and if they're positive, if those disproving tests say that the H3 is not the diagnosis, then we have to review the whole thing again. So we look back on the diagnosis to see where we've gone wrong. Coming down, if the biceps tendinopathy proves to be correct, then we have our diagnosis. So H2 now becomes a diagnosis. If the other tendinopathy proves to be correct, so we picked up the biceps tendinopathy failed, but say supraspinatus tendinopathy is okay, then we attack it again with the EIS, and if this fails now, we go to H4, AC pathology in this case, attack it with the EIS. If it's good, we've got our diagnosis. If it fails, then you're going to have to do a complete examination of the shoulder. Basically, everything's going to have to be examined in full. And if all that fails to generate a diagnosis, then bursitis is a reasonable diagnosis at that point because it's a diagnosis of exclusion. If the bursa is actually inflamed and you can see the swelling and so on, then that's going to be your first hypothesis. That may not be the only problem in the shoulder, but that's going to be your first hypothesis, and you're going to prove it by knowing what you're palpating. That it's over the swelling and it's painful and it reproduces the pain they're complaining of. So this is proving the hypothesis rather than disproving it. Okay, so let's look at the alternate method. This one looks more complex, but there's less to it actually, and I'll explain that in a second. So we've got the same hypothesis going in, degenerate labral tear. We attack it with disproving tests first. So in this case, quadrant tests. If the quadrant tests turn out to be negative, then it basically refutes H1. If the quadrant tests are positive, then you then attack the hypothesis with the EIS, and now you try to prove it. But in this case, we're saying that the disproving tests refute H1. So you generate H2, which is biceps tendinopathy again, and again you attack it with tendon palpation, for example. It's a disproving test. And if that refutes it, then you move on to H3. If it doesn't refute it, again, you then attack the biceps tendinopathy with the EIS. But if you think about this, this now is 10 tests you haven't done and 2 that you have done. You haven't had to do the full EIS on either of these things, which has saved you about 10 tests, just the single disproving test. So we've saved ourselves a lot of effort as far as testing is concerned, and more importantly, there's less to remember when you're thinking back on what's positive and what's negative. So if we refute that, then we move to H3, which is another tendinopathy. Again, you apply disproving tests, palpate the tendon is your best bet, looking for it to be negative. If that's negative and it refutes it, then move on to H1. So we're going to go back to a degenerative labral tear, because we know it's not an AC joint problem, almost certainly, because the quadrant test was negative when we used it to disprove the labral tear. That should also stress out the AC joint. So as far as we can disprove these things with a single test, we don't have to worry about the AC joint yet. If the disproving test failed to refute the hypothesis, then we're going to attack that hypothesis again with the EIS, which is going to be contractile tests. If the EIS is good, then we've got the H2 becoming the differential diagnosis. Same pattern, all we're doing though is trying to disprove the hypothesis rather than trying to prove it. And what we've done in the process is saved ourselves about 8 different tests and trying to remember where we are in the process. Although script focus does reduce the amount of things you have to remember because it's an ongoing process and you have a new hypothesis each time, This will also reduce the amount of remembering that you have to do and integrating the information that you have to do. Now we're going to continue this on the next slide. As I say, it looks complicated, but actually it's less complicated. Okay, this will take up where we left off. So we came in returning to a degenerative labral tear because we'd basically disproved all of the other obvious causes of anterolateral shoulder pain. So now we're going to come back to the first one because we can't be sure that these quadrant tests that we did here are good enough. They may not be for this. So assuming that is better than assuming the other thing. So we assume that, and now we have to basically prove our hypothesis rather than disprove it. We've already disproved it once, so let's not do it again. So now we're going to treat it as if, as we would do normally, and that's to disprove it, as to prove it rather. So we attack it with the EIS. Mostly this is about O'Brien's and load shift tests, and whether one or both are positive or neither of them are positive. And we talked about that previously, and I'm not going to go into that again, but one of the tests needs to prove that the labrum is painful, which is O'Brien's test, and the other one needs to prove that it's mobile or fragmented. Now, don't forget what I said though. The load shift test may not be negative if the labral fragment is cool, so you may not get it clicking, in which case you're going to have it jammed, and that's when you're going to manipulate it. So let's say that you attack it with the EIS. The EIS is good, you now have your diagnosis. If the EIS is bad, then we shift on to another hypothesis, in this case now AC joint. We didn't do it before because the quadrant test will test the AC joint as well as the glenohumeral joint. So we're going to make the same assumption though, that the quadrant test simply wasn't good enough for the AC joint pain to be made present when we did this. So we're going to look at the AC joint and we're going to attack it again with the EIS. Cross-body adduction maybe, but certainly joint palpation, grinding the joint for pain, and then maybe a biomechanical examination if we believe it's a biomechanical dysfunction. If the biomechanical exam is negative, it doesn't mean to say that there isn't a joint problem there. This could be a minor arthritis, could be a number of things, a meniscus tear in there. Well, it's all rubble anyway, but you may have a problem with the rubble. So, but we do know it's not biomechanical dysfunction. So if the EIS isn't good enough, or is good enough rather, then we have our diagnosis. If the EIS isn't good enough, then we need to check the whole shoulder, a proper examination of all the shoulder, all of the muscles, all of the joints and so on, and then that may render a diagnosis, and if it doesn't, then we can probably say with some degree of happiness that this is a bursitis. And we can then prove that by palpating the bursa directly. If it's swollen, that would actually be your first hypothesis. If it's swollen, then you would go for bursitis as your first one. But if you now you know where you don't want to palpate over the tendon, now we can palpate where the bursa is if we can reach it, and we can do other tests that may catch a bursa as you're doing it. So, but remember that the bursitis is an exclusionary test. You get rid of all the other possibilities, and that's what you're lumped with. If that's all negative, if your palpations over the shoulder are negative, really you have no idea what's going on, and this should be referred back for more investigation by the physician. Okay, so we reviewed differential diagnosis, both from the way it's done in medicine, and that may well be the only way it's done in medicine, is trying to prove each differential diagnosis in turn. But we've also done it from another perspective where we try to disprove it. For us, I think that one definitely makes more sense. Apply a screening test. If the screening test is good, you can throw out that differential diagnosis, at least provisionally. You never throw things away completely. It might be an outlier, it may be atypical. There's a number of things that can do this, but not many. If you have a really good sensitive test, either for that condition when it's negative or another condition when it's positive, then you can start thinking about throwing it out. But that's the value of a sensitive test. If it's not positive when it should be, that condition is probably not present. So we looked at differential diagnosis, the value of high sensitive tests in dealing with differential diagnosis, and we've looked at strict focus hypothetical inference from the perspective of proving it by attacking it with the EIS, or disproving it by attacking it with a highly sensitive test that turns out to be negative. Okay, so I'll talk to you again soon. Take care, everybody. Bye.